So good evening, good morning, good afternoon, everyone, and thank you so much for joining the webinar today. We have an excellent panel of speakers who are going to be sharing their experience in the disease state management of diabetes. So the title of our webinar today is Pharmacist's Role in the disease state management of diabetes and prevention of complications. Next slide, please. So it's my great pleasure to be the moderator today. My name is Tim Chen. I'm the president of the Social and Administrative Pharmacy section, and I'm from the University of Sydney in Australia. So you can see we have an excellent panel of speakers for today. And I will be introducing the speakers in turn as we come to them. So as usual for the FIP webinars, just to let you know that this webinar is being recorded and it's being live streamed on YouTube. The recording will be available by the FIP website. At the bottom of your screen, you'll see an opportunity to ask questions using the questions box. As usual for all of the webinars, there's an opportunity to provide feedback, and the address is here. And also I'd encourage you to join FIP membership if you haven't already. So in the FIP, there are a number of development goals. The webinar today is pertaining to development goal 15, people-centered care. And in this webinar today, we're talking about non-communicable diseases. We're talking about diabetes in particular. On this slide here, we can see a number of really important things from the management of diabetes perspective. At the bottom, we can see healthy subjects. Pharmacists could have a role in disease prevention and health promotion. At the next level, we can see medium and high-risk individuals. So here we can see pharmacists have a role in screening and referral. And then at the top of the pyramid, we can see diagnosed NCDs, diabetes. Pharmacists have a significant role in disease state management and treatment optimization. Next slide, please. So this webinar is part of a series on diabetes management. Today on 22nd of October, you can also see on this screen webinars on 29th of October on therapeutics, treatment optimization and support technology. On the 5th of November, we can see a webinar on competencies and workforce development. And then on 12th of November, we can see an important webinar on transforming pharmacy practice, improved care and diabetes management. And so this webinar on the 12th is going to be launch of publications and a microsite, and it also coincides with World Diabetes Day. So as usual, we have a number of learning objectives for our webinar today. We have 3. So the first one is to describe the different services provided by pharmacists to manage diabetes. Our second learning objectives is to identify the role of pharmacists in preventing the complications of diabetes. And our third objective is to understand the importance of collaboration with other diabetes healthcare professionals in achieving treatment goals. Next slide, please. So for our webinar today, we have 90 minutes. We have 4 excellent speakers. Each of the 4 speakers is going to be speaking for about 15 minutes. And then at the conclusion of the 4th speaker, we will have a panel discussion And in the panel discussion and Q&A wrap-up at the end of the fourth speaker, I'd encourage the participants to ask questions or provide comments using the Q&A function. Next slide, please. So it's my very great pleasure to introduce our first speaker today, Dr. Sana Hassan. Now, Dr. Hassan is an associate professor at Amjan University in the UAE. She received her PhD from Monash University in Australia, and she also has a PharmD, which she received in 2002, and her BSc in pharmacy as well from the University of Kansas in the USA. Dr. Sana has considerable hospital pharmacy experience and community pharmacy research. She has had faculty appointments at numerous academic institutions, and she's currently working at Amjan University in the UAE. She's also been an invited speaker at multiple regional and international conferences, and importantly, she's been the principal investigator on several research projects on pharmacy practice and community pharmacy. So please, can you join with me in welcoming Dr. Hassan to the virtual podium? We look forward to your presentation. Thank you very much.
Okay, thank you very much, Timothy, for this nice introduction. And you said my name correctly. Nicely, you did pronounce it correctly, so thank you very much. All right, what I will do today is introduce an overview of different disease management services that have been provided worldwide up to date, and a little bit of a historic overview of how this has evolved into what it is right now, and what else could be provided by pharmacists in the future. All right, so just to introduce the subject, according to the International Diabetes Federation, there are approximately over 460 million adults, 1 in 11 adults aged 20 to 79 year olds who are living with diabetes globally right now. This number is expected to rise to 700 million by the year 2045. Over the last 20 years, the number of people or adults who are living with diabetes has actually more than tripled. And of those who are living with diabetes, almost 80% live in low and middle income countries. And about 1 in 5 of those are above the age of 65. So looking at older people, maybe obviously living in less resourced countries, low and middle income countries, and hence the need for more intervention by different healthcare providers and especially pharmacists in this context. The IDF estimates that approximately 4.2 million adults will die annually as a result of diabetes and its complications. So this disease carries a tremendous burden on the individual and societies, on governments globally, and hence healthcare providers really need to not only collaborate, they need to use their knowledge, their expertise, their skills in order to help out these patients and help lessen the burden of this disease on the individual and on institutions and on the globe, basically. Specifically here, we're talking about pharmacist interventions. What has been noticed and is still the case basically is that there is a significant gap between reaching the goal of optimal medication therapy and the current state of medication use that is actually happening in many disease states, not just diabetes. So there is this gap of what is optimum and what is actual. And this is where the responsibility of the pharmacist comes into play to really reduce or narrow this gap that is actually occurring. Pharmacists are highly accessible and well-trained overall, but yet they're often underutilized, really, maybe in all countries developed or developing, and they're key healthcare providers, and they are underutilized, despite the fact that they are well-trained and accessible. So this is something that we also need to work at. The pharmacists overall, they can help assure that the patient is getting safe and appropriate, cost-effective medications, in this case for diabetes, and that, with that, we help to achieve better outcomes from the disease state management, obviously, in this case for diabetes. All right? Okay, so overall, what we know now is that pharmacists have contributed for diabetes management with many roles, including adopting direct provider care role, whether doing that individually or whether doing that as members of the healthcare team, as part of an interdisciplinary team. They are providers of education, whether within their own individual capacity, with their own basic training, or as certified diabetes educators. They are providers of pharmaceutical care, where individual patient-centered care is the center of care, whether they are doing it in a dispensing fashion or as consultants. And so how are pharmacists doing this care for diabetes specifically, and in general, obviously, for other diseases, but our program today is about diabetes. They're doing that in different ways. One that is very important is through collaborative care teams. And this is obviously done now in many countries, where through what's called collaborative drug therapy management, where pharmacists and physicians develop a protocol together in which the pharmacist is enabled to provide different services and different care issues for patients under a protocol that they develop along themselves with the pharmacist, with the doctor, and the training requirements of the pharmacist are usually agreed on or actually spelled out in the protocol that is developed with the physician, and what it is exactly that the pharmacist is going to do is spelled out in this protocol. Usually this involves carrying out patient assessments. Some of it is physical assessment, as much as the laws and regulations are allowing the pharmacist to provide these services in a specific country. They can order lab tests under these protocols. They can initiate, monitor, adjust medication regimens under these protocols, and they can administer medications, obviously. So this is all spelled out in this protocol within these drug therapy management protocols that are usually kind of like a signed agreement with the physician. And as I said a little bit ago, is that the training requirement that will enable the pharmacist enter into these protocols with the physician is usually agreed upon before any formal agreement is done. And what it is, the services that the pharmacist is going to provide is established before a formal agreement. And this usually starts with familiarity, when the pharmacist and the doctor are familiar with the presence of each other, and that they are, they know what services that could be offered by the pharmacist, and the pharmacist is ready to work and collaborate with the doctor, and then a formal agreement is reached upon. And then the services could be provided by the pharmacist in collaboration with the doctor. Most of these agreements cover complex patients with multiple disease states, multiple chronic conditions, and they require higher level intervention from a pharmacist in order to optimize the outcomes from medication use, including prevention of medication-related problems and drug interactions, and optimizing the outcomes, clinical outcomes, humanistic outcomes for the patient by the pharmacist. So that's the collaborative care teams. Next, please. Okay, I do want to shed a little bit of light on some historic programs that really have been pioneers in establishing the role of the pharmacist in achieving better outcomes for patients, and specifically here in diabetes management. And that is the Asheville Project, which was initiated in the US in 1996. Basically, this is where two employers, including the Mission Health System and the municipal government, basically started a program where specially trained pharmacists met with patients with diabetes, and the employees made regular visits with the pharmacists, with these trained pharmacists in a network, and the pharmacists provided care services, monitoring, and counseling under this agreement. The employers paid the pharmacists for these services under this program from the beginning for the pharmaceutical care services they provided, and they waived co-pays for the patients, medication and supplies. Obviously, patients had to pay, they had insurance, but in this case, the employers waived the co-pays on the medications and the supplies in order to encourage the participants or the patients to participate in this program. The services provided by pharmacists included, please, can we go back? Setting and monitoring diabetes, treatment, establishing treatment goals, home monitoring of glucose meter, training of the patients on home monitoring and on adherence strategies. Other services they provided basically included diabetes and lipid management education, specifically education. They did physical assessment of patients' feet, skin. They did blood pressure measurement and weight measurement, obviously, and referred patients to their physicians for if the patient needed that, obviously, depending on the patient case and the findings that the pharmacists have acquired when they did this patient assessment. Clinical and financial outcomes that have been achieved out of this project included mean A1C values and lipid levels decreased for more than 50% of the participants with every measurement. And at 6 months, about 1/4 of these patients had optimal A1C values of less than 7% compared to baseline. And 7% is usually the A1C value goal for most, not all patients, but most patients that we aim for. So at 6 months, about 1/4 of the patients had optimal A1C in comparison, achieved an A1C level of less than 7% in comparison to baseline. What else has been achieved? Emergency department visits occurred at 1/3 less than national average. Total direct medical costs were less by about, the savings were about $1,600 to $3,300 per participant. And the average reduction in participant sick days was about 41%. So it was estimated the return on investment for employers was about 4-to-1 for diabetes. So these were very nice clinical outcomes that, and maybe some humanistic, because we have less sick days as well, outcomes that have been achieved from the Asheville project. All right, another project that really built on the success of the Asheville project was done by the American Pharmacists Association Foundation, which established the 10-City Challenge in the year 2005 that involved 10 communities, basically, and I think 9 were really sustained into completion throughout the program. This innovative program for employers and communities to fight diabetes and reduce the healthcare costs. Basically, what it involved is incentivizing a voluntary health benefit program for employees and their dependents. The services that were provided in this program were very similar to the Asheville project, including establishing goals, optimizing medications, counseling and education, adherence issues. So they were very similar just like the Asheville project. And what kind of outcomes did we achieve in this program? These were observed over a 1-year period, including decrease in the A1C, an average of 0.4% in that year for all participants. LDLC, mean change of minus 3.4 milligram per deciliter. Blood pressure change by reduction in by the amount of 2.4 millimeter Hg. BMI, mean reduction by 0.4 kilogram per meter squared. Influenza vaccination rates that were increased from 43 to 61%. Eye examination that went up from 60% to 77%. So increase in the utilization of healthcare services. Foot examinations were increased from 38 to 68%. So we're looking at tremendous clinical outcomes that have been achieved, financial outcomes, savings of about $900 per employee for the employers in total healthcare costs per year, 50% reduction in absenteeism, fewer workers' compensation claims, litigation, average employee savings. Now, these are employee savings, employee, not employer, by about $400 to $600 dollars per year because they have been incentivized to, such as waiving the copays. Those who also we're looking at humanistic outcomes. Overall, patients who perceive their overall health care, diabetes care was very good to excellent, increase from 39 to 87%, and high employee satisfaction, 95 approval for pharmacists being part of as managers of their disease state here, and improved quality of life. So we're looking at historically two major milestones in basically enhancing and in showing the roles that pharmacists could play in and achieving better outcomes, humanistic, clinical outcomes, cost effectiveness outcomes for patients with diabetes. Of course, after that, we saw a revolution in diabetes management and pharmacist roles and interventions, including medication therapy management and medicines management schemes that were adopted by either government in globally in countries in the mainly developed world, in Europe, Australia, in South America, in the Americas, obviously, where pharmacists are involved and possibly also reimbursed for the services that they provide through what is called medication therapy management schemes or medicines management schemes. And these obviously, as we said, they're either done through government established schemes or institutional network type of services where pharmacists are involved. And these services have been provided in community pharmacies, in outpatient clinics, in tertiary hospital-associated diabetes clinics, specific diabetes clinics that are not associated or associated with hospitals, in ambulatory care clinics, primary care, internal medicine clinics, community health centers, or the Veteran Affairs medical centers in the U.S. So they've been provided in different kind of settings, and more inpatient or outpatient clinics, or in outpatient clinic associated standalone clinics, or those that are associated with community health centers or hospitals. And so what kind of services did the pharmacists provide, including establishing personalized goals for patients, for their therapies, conducting comprehensive medication reviews, including diabetes and other disease states. When we talk about comprehensive medication review, that includes different disease states as well that the patient is suffering from, designing drug monitoring and monitoring drug regimens, adjustments to medication therapies when the patient is not at goal, optimizing these regimens. Maybe, the patient is actually on their way to improving, but they're not at goal, and maybe they're suffering from side effects. Maybe the dosing is still not optimized, so pharmacists made sure that these are optimal adherence strategies, simplifying and managing complex regimens for patients, cost effectiveness. Obviously, it's not just that the medication is going to achieve clinical outcomes, but looking also at costs, performing drug interaction reviews, and discussing recommendations with the patients themselves and their providers. And other things also, education, patient education. That includes why the medications are prescribed, and respecting patients' choice in these medications, proper medication use, how to use these medications properly, how to administer medications, their storage, adverse reactions, lifestyle counseling for patients, and how to monitor glucose monitoring. They train them, and how the patient could be trained on monitoring their own, keeping records, and giving these records to the pharmacists and the doctors on their visits, and information on vaccinations and diabetes education, specifically including diet and lifestyle, nutrition, the types of foods that are diabetes friendly, the DASH diet and sodium reduction, which are going to be good not only for diabetes, but also for reducing cardiovascular risk and dealing with cardiovascular risk that is usually associated with diabetes. Physical activity, what kind of physical activity? Is it 150 minutes per week with no more than 2 days off per week? Or is it 30 minutes every day, most days of the week? And weight loss strategies. So pharmacists provided many services and achieved many outcomes because of these services, obviously. And that includes clinical outcomes such as glucose level reduction, A1Cs within normal ranges and values and goals of therapy, blood pressure goals achieved, lipid, weight, BMIs, quality, all right, health-related quality of life, medication adherence, many things, many outcomes, including humanistic outcomes and clinical outcomes. So patients really were happier also with the services. They used the services more, adhered better when a pharmacist was involved in their medication therapy management. All right, so to conclude this is that we want to obviously make sure that the pharmacist is reimbursed for the services that they are providing. And, pharmacists need to be creative in the ways to secure reimbursement. And maybe this requires them to document the outcomes from their interventions, including, economic, humanistic, and clinical outcomes. So there is much role that the pharmacist could play with diabetes management into achieving better outcomes for patients. Patients want these services, and there is a need for much more involvement from pharmacists. And thank you very much, and happy to answer any questions or discuss any comments. Thank you.
Thank you so much, Dr. Sana, for a wonderful presentation. I especially like the fact that you told us about two seminal diabetes projects, the Asheville Project and the Diabetes 10 City Challenge. We're in fact going to keep the questions and the comments to the end for the panel discussion. I also really liked how you framed the outcomes of the various studies using the ECHO model with economic, clinical and humanistic outcomes. That really is very important for disease state management. So now it's my very great pleasure to introduce our second speaker for today's webinar, Dr. Astrid Jock, who's CEO of QualiCare in Switzerland. Now, Astrid has a Master of Pharmacy and a PhD in pharmaceutical chemistry, working specifically on morphine derivatives from the University of Vienna in Austria. And she has worked in R&D on new cancer treatments in the US as well. After working for 8 years as a community pharmacist in Switzerland, she took up the important position of Department Head of Science, Education and Quality in PharmaSwiss. Astrid was appointed a Fellow of the Swiss Academy of Pharmaceutical Sciences for her achievements for the federal accreditation of postgrad titles in community and hospital, and the creation and implementation of vaccination services by pharmacists. Astrid is, as I've mentioned, the CEO of QualiCare, a Swiss not-for-profit association. This multi-stakeholder platform aims to increase the quality of care for patients with NCDs such as diabetes, especially in primary care, by interprofessional collaboration and national best practice piloting and implementation within the primary care setting. Currently, the main topics of interest are multimorbidity, vaccination for people with NCDs, as well as treatment for diabetic foot syndromes. Astrid also works for the Swiss Society of Endocrinology and Diabetology, where she coordinates the Society's Commission for Postgraduate and Continuous Education. Astrid is a well-qualified speaker to talk to us today. Please welcome Dr. Astrid Schock to the virtual podium. Thank you, Astrid.
Hello, everybody. Good morning, good evening, wherever you are. Thank you for the invitation to be able to speak to you. Next, please. I would like to just give you some background, some figures and facts, and then dive into the gaps and how to close the gaps, and then what the pharmacists could do, and then address some barriers and possible solutions. Next slide. So this is a picture, just some background figures to remind us of the impact of diabetes on the health systems around the world. Next, please. 7 million adults will have diabetes by 2045 if we don't do anything or to decrease this rise of diabetes in our population. Next slide, please. What is really impressive, though, are the figures of the undiagnosed diabetes, which is like about 50% globally. Only in Europe, there are over 40% which are not diagnosed. And this is the people often find out that they have diabetes when they get a foot ulcer or they have a kidney failure, which is incredible to think that at our day and age, there's still such a lack of diagnosis. And so the only thing that can happen is screening. So here the pharmacists can show their importance in the prevention. The defined risk, which you can see now, diabetes risk calculator has been proven once again to be the best, as a recent study from Lausanne over 7 years showed. Again, I saw it's the defined risk is the risk calculator. It comes from Finland originally, and in Switzerland it is used for testing and is very relevant. I know there's a study in Norway which said it's not as accurate as in Finland, but for Switzerland it is, because like we had it tested, and and this is also, we have an online one if you want to have it, the same risk calculator in German, French, Italian, and German, French, and Italian, not in English. Next slide, please. And the rising costs is with over 50% of the direct costs are related to treating the complications, which is really something that we have to keep in mind, and what is their role. We have to really focus on the secondary complications and their prevention. So what are these complications? They are diabetes, they have cardiovascular diseases, which is still the highest mortality rate, more than cancer, retinopathy, and kidney failure, which is also something which is not very well addressed nowadays, and the diabetic foot complications, which lead to amputations. Next slide. So after the OECD report on healthcare systems mentioned that Switzerland had a very good health system. It might be quite expensive, but it's one of the best healthcare systems. They also reported that the quality of care for chronic patients still can be increased, and there are a lot of gaps. So the project Quality Care was launched under the umbrella of the Federal Department of Internal Affairs to analyze these gaps in the care. And they took two chronic diseases as an example. They took diabetes and COPD. And the analysis was done by comparing the care in Switzerland with other countries, and this, you can see on this slide, is pinpointing 3 major areas where there are the gaps. In Switzerland, medication is well addressed, but screening, self-management, and the control for secondary complications has a big lack in the care. Next slide, please. So multi-stakeholder group was put together during this project, and these multi-stakeholder platform, they defined the following 6 measures regarding diabetes. So it was first the definition of an evidence-based screening criteria, which is this find risk. It was adapted it was tested before it was launched in Lausanne, and now, as I said, like the recent study just came out that it is still valid. Then we addressed the foot care for diabetes patients. There was a political motion in the parliament that the podiatrist should get reimbursed for the foot care of diabetes patients by the basic health insurance. It took 10 years to establish this, but now since next year, as of next year, they're allowed to be paid, the podiatrists. There are new healthcare providers also. And then the criteria for self-management, and there was also the standards for software providers, which was never followed through because the software providers, they wanted money to implement it, and nobody had the money to do it. And then what's very important was the diabetes recommendations for primary care providers. And this is, next slide, please. This is also to say, this is a way to, these measures were to close the different gaps. So to close the gap of the best practice recommendations for primary care providers was done by the Swiss Society of Endocrinology and Diabetology, and the working group of the disease management diabetes was established, developed this criteria catalog, and it is based on the patient population, not on the individual patient. And 80% of the population of the practice of the office should achieve the goal, which leaves some space for the doctor not to include patients who are too frail or at the end of life and still can achieve the goal. So the office can still achieve the score. So as we saw that the foot examinations were not performed sufficiently in the primary care offices during the time when we tested the 2 pilot, the criteria in the 2 pilot projects we did, we increased the points in 2017. So they get a higher score if they perform this criteria, the foot control. And also, we also changed the eye control, because the ophthalmologists often didn't have time to see the patient, or they said the patient doesn't have to go to see the patient every year. And what we also kept, which was a discussion point, was the LDL measurements if the patients take statins, because at some point in the US, which we in Switzerland, we refer that guidelines always to the ADA from the American Diabetes Association. And they had stopped the measurement of the LDE if patients take statins. But for us, it was very important to keep this measurement, because just because you prescribe the statins does not mean that the patient takes it. And maybe the patient doesn't react well to the statins. So this is like the reason we kept it. And now we did a third pilot with 9 independently owned GP offices. And here you can see that the outcomes, it will soon be published. We are still in the preparation of the publication of this study. And you can see the gaps. In 2014 was when the first pilot project was performed. It had exactly the same gaps, except that there was still some lifestyle measures which were not achieved. But once again, we see the blood pressure, the cholesterol, the neuropathy screening, the eye examination, the foot examination has a lot to increase. The black lines are, they show the to be achieved goal, and the gray lines were the first when the doctors looked what was documented retrospectively, and after they were aware of the criteria, that was the blue lines. So there was an increase after the awareness. In this project, we also added 5 statistical measures regarding the medication, the oral antidiabetics, the insulin, the antihypertensive medication, the statin therapy, and the influenza vaccination, which is another gap, which is very important. And we to keep in mind, 37% of the diabetes patients in these offices were only 37% were vaccinated against influenza, and this is can be. We also on Quality Care also performed another project regarding influenza vaccination in the population, and we had the same results, not only for diabetes, but we were looking at NCD patients in general, and it had the same. It also said like 36 or 37% were vaccinated. This other study is going to be published in the Vaccine Journal. So next slide is, so what can the pharmacists do? They can close these gaps, which I just highlighted, which were the gaps made in the GP offices. That means we would be supporting as pharmacists the GPs in achieving the optimal care for diabetes patients. So the general prevention measures like lifestyle, this has to be done for all NCD patients. I think this has to be really a routine standard care that we always address: lifestyle measures, diet, physical activity, tobacco cessation. In some countries, there are structured tobacco cessation standards or motivational interviewing. In Switzerland, we have this, but it's also not reimbursed. And I don't know how many pharmacists are actually performing it. I think this would be a good way to also highlight our role. And then the measurements, wherever, if the pharmacy, every pharmacy can measure the blood pressure. And as far as I know, they do that. And if the pharmacist and the GP does it, then maybe you can also compare the values. Maybe the patient is more nervous in the doctor's office or stressed. So I think it's important, if you can make blood sampling, that you can also do measure the cholesterol. And I don't know if the creatinine or microalbumin can be measured in your pharmacies, but if your country allows you to do this, I think you should do it. Otherwise, it would be good to maybe have a collaboration with the laboratory or with a GP who can delegate it to you. Next is we should always remind the patient to see their ophthalmologist at least every 2 years. And of course, the pharmacist can check the foot sensitivity, and of course, vaccinate the patient against influenza, because as you see, this is a major gap. I mean, we have to have a coverage with at-risk patients over 75%. And we are far from that in Switzerland, definitely. And regarding the regarding the diabetic foot, why would we want to do that? I mean, we showed in the Canton Vaud, there was a diabetes project for over 10 years, and they could show that through interprofessional collaboration, where you had every healthcare provider working together to check the foot sensitivity, they showed that they can reduce the amputation rate next. Up to 85% of the amputations can be prevented, and as you saw on the picture, that in Switzerland, in general, all of Switzerland, the amputation rates stayed high, and in the Canton Vaud around Lausanne, it went down. So the burden of disease is very high. This whole program, the diabetes project, cost about 1.5 million Swiss francs annually, but the direct and the indirect costs of the amputations and the dialysis were over 500 million, so annually. So this, you can see the big difference if you invest. Also, it's a very important message to the government to invest, and this is the same what Sana already mentioned. Investing into prevention saves a lot of money and a lot of human costs, because nobody wants to go into dialysis or have an amputated limb. So for the another recommendation, which was elaborated during the project period of Quality Care, was these corner points of diabetes foot management in primary care. This regards the prevention of diabetic foot. It's adapted to the guidelines of the International Working Group of Diabetic Foot from 2019, this risk stratification. I don't want to go too far into this topic. There was a previous webinar on July 28th, which you can watch on the FIP events page. It's called Supporting Self-Care, Foot Care and Diabetes Management. Next, please. Only in short, I want to mention our most recent project regarding the diabetic foot syndromes, which is the curation and what the pharmacists can do in there. We had created an interprofessional working group with experts, representatives of 12 different professions, and adapted the guidelines from the International Working Group Diabetic Foot to Switzerland. And we involved all professionals who might see wounds on feet of diabetic patients. In this practical guidance, we had everybody have one guidance for everybody, and it's very important that every pharmacist who sees an open foot asks if the patient is diabetic, and if yes, ask also how long, since when is this wound open, and they have to refer the patient, next please, in a timely manner to the right onto the right next level. That means if a pharmacist sees a patient and the wound is open since about 5 weeks, he should not send the patient to the GP. He should directly send the patient to an interprofessional on-site foot care center, because time is tissue, and also the GP has to refer the patient after 4 weeks. The reason why the GP is on a higher level is because he can prescribe antibiotics, so he can also care for mild infections. Next, please. So to close up, what are the barriers and the possible solutions? So no remuneration is very often the case. I think you saw a lot of ideas also already in Sana's presentation earlier, that there were pilot projects, and it is very important to do pilot projects together, maybe with payers, healthcare insurances, government, to show the outcomes and then also calculate the costs for the healthcare system and the economy, because if a patient's sick days also falls down to the economy. And the other topic point could be that there are not sufficient competencies with the pharmacists. This is very easy. You can just educate them in specific topics, accredit if necessary. And if you have no resources, collaborate with other pharmacies, with other healthcare professionals to save the resources. In the coming years, the resources are getting less and less because the demographic changes with people getting healthier and living longer. But then, of course, if they live longer, they will have longer chronic diseases. And also, if you have problems with other professionals saying that maybe they don't want you to do certain services, you have to address the issues directly, engage in the dialogue, and inform them that you're not taking away their job, but more you are supporting them and helping the patient. So this is all, and I thank you all for your attention. And back to you, Tim.
Thank you very much, Astrid, for a wonderful presentation and for sharing data from across Switzerland, across a number of studies at the national level and at the level of the canton. I think it's really important how you showed that screening is important and monitoring of secondary complications is critically important to identify the gaps in care, and importantly, how pharmacists work as part of multidisciplinary teams to help fill some of the gaps which have been identified. So we thank you for your presentation. So it's now my great pleasure to introduce our third speaker today, Dr. Francisco Javier Jimenez Ramirez, who is a professor at the University of Puerto Rico School of Pharmacy. Francisco has been a pharmacist since 1995. He graduated from the University of Puerto Rico in 1995 with a BSc in pharmacy. From 1995 to 1996, he worked at the Cardiovascular Center in Puerto Rico and also in the Caribbean. He completed primary care pharmacy residency program, 96 to 97, at the Caribbean VA healthcare system in San Juan. After working at that, he decided to complete his Doctor of Pharmacy, his PharmD degree, and he did that in the States at Temple University in Philadelphia. In 2001, he began his professional career at UPR, University of Puerto Rico School of Pharmacy. He has acquired a number of postgraduate certifications, including diabetes care education specialist. He's also a board certified pharmacotherapy specialist, and his special interest is in diabetes. I've had a look at the slides. There's an excellent slide set to follow. Francisco, we welcome you to the virtual podium and look forward to your talk. Thank you very much.
Morning. Good morning. It's my pleasure being here from Puerto Rico to share my experience with you. It is a pleasure because I come from a pharmacy owner and pharmacist in Lares, Puerto Rico, and that's where my passion for pharmacy comes, and specifically for community pharmacy. My mom is a pharmacist. My aunt is a pharmacist. My dad and my brother are accountant and pharmacy technicians too. So that's where my passion for community pharmacy comes. And I really believe that community pharmacy has a lot to provide to the community health. And we have a lot of opportunities that we miss. And I agree with Dr. Hassan that we need more pharmacists to get involved in diabetes care and other disease management too. For me, the community pharmacy is more than a medication distribution center. It is a place to provide healthcare services, and we contribute to our population needs, as I am going to show you. Next, please. Next. I'm going to share with you some work that I have done in the past. The first thing that we did was to evaluate the needs of the community. And as we all know, many people have many comorbidities as hypertension, hyperlipidemia, retinopathy, renal diseases, and other comorbidities that we can prevent from the community pharmacy. Next, please. In that small work, we realized that glucose is poorly controlled. 67% of fasting patients had glucose over 140 milligrams per deciliter in all groups compared to people who don't have diabetes. More than 65% didn't check their blood glucose more than 1 month ago, as you can see in the peak. Not many people was monitoring their glucose at that time, so we did a good job on that. Next. People didn't know what A1C was, and at this time, there is not much difference on that. If people know what A1C is, they don't know the result. So we need more people to know what A1C means and what we need to do to reach the goal. Next. The same happened with many diabetes screenings or care as ophthalmologist evaluation, renal function evaluation. Not many people were receiving that services. Food examinations, as mentioned Dr. Chuck before. Not many people were doing their self-fit assessment, etc. Next, please. Nutritionist evaluation wasn't happening either. Not many people were educated and following a meal plan. Next. And they were not receiving diabetes education either because there were no services to provide that education. And the community pharmacy is a great place because people come to the pharmacy very often, many times during the month. For that job, we demonstrated that diabetes management and education was necessary at the community pharmacy, and also that the community pharmacy is an excellent place to provide this service. And also, we wanted to demonstrate that diabetes care is responsibility of all health-related professionals. In this job, we included a nutritionist. Also, we send the recommendations or the information to the primary physician, and also a medical technologist from a lab. Next, please. Then we provided the service to monitor outcomes, and we evaluated economic, humanistic, and clinical outcomes. That was the objective of the service. We wanted to evaluate how successful we were, and we were successful in that job. You can see the glucose control improved, A1C improved by 1%, as you can see in the graph. Next. Fasting, people who had A1C over 8% decreased from 54% to 31%, and people who reached the goal increased from 25%, as you see in the bottom, to 39%. It wasn't statistically significant, but the A1C over 8%, it was statistically significant, the difference from 54% to 31%. Next, please. The same happened with fasting plasma glucose, decreased also the level, and it was statistically significant too. People who had values over 140 decreased significantly too. Next, please. The same happened with blood pressure. We had improvement. Next, please. Lipid profile improved also, especially LDL decreased from 120 to 106, close to the goal of less than 100. Many people definitely improved. As you can see in the graph, we also check urine protein to detect renal disease at early stage. Go ahead, please. Creatinine clearance was also evaluated in the pharmacy. and the results were sent to the primary physician to take action over them. Next, please. Weight also decreased a little bit. There was no significant difference. We didn't concentrate a lot on the weight. I know that this is really important. Next, please. Antiplatelet therapy also improved. Not many people were taking antiplatelet therapy, and it increased, as you can see in the middle, from 30% to 50% of the patients taking maybe Plavix on aspirin. In general, all clinical outcomes improved. As you can see on the right side, all were significantly, except weight and protein, urine protein, but many people also improved. Next, please. The goals achievement also improved in the majority of the patients in post-intervention. As you can see, LDL improved, A1C improved, all clinical parameters improved in this service. Continue, please. And patient with clinical improvement was about 60% in all parameters, so it was good. Next. And also the diabetes-related knowledge improved from less than 70% to over 80% in this population. Next, please. We also did ophthalmology services in that project, fundoscopic exams for many people, and people were identified to have diabetic retinopathy at early stage. Next, please. We also did immunization services to prevent infectious diseases as pneumococcus and influenza and other diseases too. Next, please. In conclusion, it was effective improving clinical and humanistic outcomes, not necessarily the economic outcomes. What is the gap that we need to solve, as mentioned before? I was in collaboration with the physician and nutritionist. Next, please. It was a poster that shows all the information that I presented. It was presented at the American Association of Diabetes Educators a long time ago. Next. Another good work that we did was identifying diabetic retinopathy screening and education at the community pharmacy, that it became a rural mobile diabetic retinopathy screening service with an ophthalmologist. And the question was if at the community pharmacy we were able to promote the diagnosis at early stage and increase the knowledge of the population of these screening exam required annually. Next. Basically, that was the purpose, increase the diagnostic and knowledge about diabetic retinopathy. Next. We took ophthalmologists to the pharmacy, and in the second work, we had a camera to take the picture, and it was sent electronically to the ophthalmologist for evaluation and recommendations, and we hand into the recommendation to the patient to take it to the primary physician and being referred to an ophthalmologist for further evaluation. 38 patients were diagnosed with background diabetic retinopathy at that time. Next. That's about the same. 90% were at early stage with background diabetic retinopathy, which means that we can prevent progress of this disease. Next. And as you can see, 80% or more were at the initial stage. And we were able to work with these patients to prevent further progression, which should be next, the next evaluation to see if we were successful. We can focus on prevention and early detections at the community pharmacy, control, not just glucose control, also other comorbidities to facilitate the screening of these complications at the community pharmacy. Those are some pictures of the services provided. Next, please. Those are examples of the pictures taken of the retina in the pharmacy. Next. The same. Next. And I had to pause a little bit to promote the development of the immunization services at the community pharmacy in Puerto Rico to prevent diseases. Many people have diabetes, at least 50% of the patients that benefit from the service. Next, please. And you know that the role of the pharmacist at the community pharmacy is huge. Starting with the evaluation, education, identification of the patient, recommendation, then administration of a vaccine, following up to complete the series, following up for adverse effects, etc. So that's a process. In Puerto Rico, we at the School of Pharmacy, we train over 600 community pharmacists, especially over 300 that work at community pharmacies to promote the development of the service. We have been successful on that aspect. Next, please. As you can see, since 2016, when we started the immunization course in collaboration with the American Pharmacists Association, it increased from 150 pharmacies, community pharmacies, to 350. And the thing is that of that number, the majority of them that increase are independent community pharmacies. In that numbers are included chain pharmacies, and in independent community pharmacies in 2016, we had about 25 pharmacies. Right now, we have over 175 pharmacies, independent community pharmacies, plus chain pharmacies. Next, please. This is a health festival that we do at the community pharmacy in my hometown, Lares, Puerto Rico, yearly until 2017. After Hurricane Maria, it was the last health festival. Then the pandemic came, etc. That's one of the first in 2004, but it started in 1996. Next, please. Next, please. This is an example of the services provided. We have over 100 collaborators, physicians, nurses, pharmacists, students, blood donation, speech and language pathology services, hearing exams, podiatry services. But that's just once per year. We need more services like that. Cancer screening. Next, please. I think that the community pharmacy is the link among all healthcare professionals. That's where interprofessional collaboration comes from, where the opportunity is. We can do diabetes education, diabetes management. We can do diabetes-related chronic complication screening, immunization, MTM or medication therapy management services, and integrate all physicians. We are the link between the physicians, the laboratory, etc. Blood donation. We have collected over 50 pins of blood in community pharmacy activities, health education, and disease prevention. Next, please. Right now in Puerto Rico, at least we have a couple of opportunities for pharmacist service reimbursement, which I have been fighting for 20 years. Immunization is one of the services that we get reimbursement, not just for the vaccine, also for the service. Medication reconciliations. There is one health insurance that pay the pharmacist for this service. At least one annual reconciliation, and every post-discharge medication reconciliation. We have one insurance that's still paying for the medication therapy management service and the comprehensive medication reviews. And there is adherence programs or services that they pay the pharmacist for the service, but it is attached to the product. You need to dispense the medications to get reimbursement. Next, please. For me, we can improve health outcomes at the community pharmacy. We are the most accessible healthcare center. Pharmacies are very accessible to the community. I guess that all panelists agree with that. We just need remuneration for our services to expand them. And I have to go back to diabetes care and continue expanding these services. And the $1 million question is how can we reach the goal or dream of getting reimbursed for my services as a pharmacist, to increase them, to enhance them, to be able to provide more services to the community and contribute to the community health needs. Next. And those are some selected references that you can take a look later. Works that I have done in Puerto Rico. I just want to mention that I still believe that community pharmacy has a lot to provide to the community health. And I hope that it continue increasing, but I hope it doesn't take as long as it has taken. And I really love to share some information with my colleagues from around the world. And please continue working hard as a pharmacist to reach that goal of getting reimbursed and continue expanding our services at the community pharmacy. Thank you very much. It's my pleasure being here with you.
Thank you very much, Professor Ramirez, for a wonderful presentation about 2 decades worth of data compressed into a wonderful talk. I really like the fact how you demonstrated the scope of practice that community pharmacy can provide by interacting with the specialist physicians in the pharmacy, using the access of the community pharmacy to provide care, and also your comments in relation to MTM and other services as well. I'm sure there'll be plenty of questions in the panel discussion at the end of the session, and I thank you again for your wonderful talk today. So now it's my very great pleasure to introduce our 4th speaker for our webinar today, Dr. Mara Guerreiro, who is from Portugal. Now, Mara is an invited professor and R&D project leader and entrepreneur pharmacist. She is driven by positively impacting people's lives through interdisciplinary research by teaching tomorrow and today's healthcare professionals. Her key competencies include research projects, leadership and management, science communication and dissemination, and digital transformation of teaching and learning for efficiency and sustainability gains. Mara has been the principal investigator on the National R&D project, FASI Self-Care, and she leads other European-funded projects as well, especially in the digital health and education technology space. She was distinguished as a fellow by the European Society of Clinical Pharmacy in 2018. She's been heavily involved in the ESCP, which has just been concluded this week as well. Her international profile is evidenced by her role in governing bodies of European scientific societies and by the organisation of international scientific events and interests in her area. Participants, please welcome Mara to the virtual podium. Thank you very much, Mara.
Thank you so much. I think now you can hear me. I was muted. So good morning, good afternoon, or good evening. It's a great pleasure to share our work and contribute to this webinar about pharmacists' role in the disease state management of diabetes and prevention of complications. I'm presenting on behalf of a team with colleagues from many disciplines, from nursing, pharmacy, psychology, sports sciences, informatics, and others. And in particular, I would like to acknowledge the contribution of my colleague Isa Felix in putting together this presentation. So let's move to the next slide. And so let me start by giving you an overview of my presentation. Firstly, I will briefly touch upon the EU policy on digital health to give some context. Then I will discuss the evidence on the impact of mobile applications to support the self-management of diabetes. The third part of my presentation will cover some examples of collaborative tools to support self-management of diabetes type 2. And I will finish by discussing some challenges in adopting these tools in practice by pharmacists. So if we move to the next slide. So the European Union has responded to problems such as aging and the need to promote sustainability of health systems with policy papers on digital health coupled to a research agenda that is very ambitious. In April 2018, the European Commission published a communication on enabling the digital transformation of health and care in the digital single market, empowering citizens and building a healthier society. And the communication vision is to make it easier for citizens to have equal access to high quality care through the meaningful use of digital innovations. The communication lays out 3 priority areas to be followed in the coming years. And I will focus on priority 3, which is about the use of digital tools for citizen empowerment and person-centered care. So it's about using digital tools to empower people to look after their health, to stimulate prevention, and to enable feedback and interaction between users and healthcare providers. In 2019, December, a resolution was passed on enabling the digital transformation of health and care. So resolution was passed to support the communication, that has been published earlier. So if we can move to the next slide. I present here in this slide a couple of examples of digital solutions that respond to priority T. So digital tools for citizen empowerment and person-centered care. And as you can see, quite a wide range of solutions from mHealth to virtual coaches and personal assistants and robotics. So a brave new world. Okay. I'm going now to move to the second part of my presentation, which is on the evidence of the impact of mobile applications to support diabetes self-management. And there is a vast body of literature on the impact of IT-based interventions. In this presentation, I'm going to focus on mobile apps to support self-management, which are regarded as a technology that is cheaper, is more convenient, and is more interactive than other IT-based solutions such as text messages and other computer-based interventions. We have several meta-analyses that show a positive effect of self-management apps in improving blood sugar control in persons with diabetes, both in types 1 and 2 diabetes. And I will show an example in greater detail in my next slide. Generally speaking, in terms of impact, results tend to be more favorable on the use of these apps for a person with diabetes type 2 than for diabetes type 1. There is less data on cost effectiveness. For example, we had a systematic review that was published on 2020 on costs and cost effectiveness of mHealth interventions for diabetes type 2. And Rinaldi et al., they included 23 studies that assess cost and effectiveness, but none of the studies actually encompassed a mobile app intervention. So in terms of cost effectiveness, there's certainly a gap here. So let us now look at an example of evidence from a specific meta-analysis. And I'm presenting here data by Cui and co-workers who published a systematic review and meta-analysis in 2016. So the systematic review included 13 RCTs on the effect of self-management mobile applications in clinical endpoints in people with diabetes type 2. 6 studies provided data for meta-analysis, including a total of 1,022 patients. Average age ranged from 45 years to 66 years. And The meta-analysis found that mobile applications to support self-management were associated with a significant reduction in HbA1c of 0.4. Okay, so if we think of clinical significance, reductions of 0.5 in HbA1c are considered generally clinically significant. So this means that the effect we have for mobile apps supporting self-management for some people may be marginally beneficial only. It should be noted, as you can have a glimpse from the first plot and the data and the I-square, that study results were very heterogeneous, which is not surprising, as there was a lot of variability in interventions. So, for example, how feedback was given to users. A few important points to put this information in context. The data that I'm presenting here, it refers to apps with a feedback system. So in other words, that returns some kind of information to data that is inputted by users. Another important point to consider is that in many trials, there was a follow-up by health professionals. So a person would input some data and then you'd have a health professional that would follow up, well, either periodically or as a response to inputted data if needed. And another important point is that these interventions that have been meta-analyzed here, they resorted to apps that were developed in-house and are not commercially available, which poses an external validity problem. Okay, so if we move to our next slide, I will now cover the third part of my presentation, which is about some examples of collaborative tools to support self-management of diabetes type 2. And the first example that I will share is from our own research on conversational agents. So I'd like just to give a bit of context. First of all, what are conversational agents? Some of you may be familiar, others perhaps not. So a conversational agent is a computer program that is designed to simulate a two-way human conversation using language, so text and or speech. And this language can potentially be supplemented with non-language modalities. So conversational agents are able to be integrated in multiple solutions, from mobile phones, web-based apps, robots, etc., with a range of goals, which could be the prevention of a chronic disease or self-management, for example. So this is an area that I've been working in for the last 6 years roughly, and this slide gives an overview of our work on conversational agents. So we started in 2014 with internal funding. In 2018, we got our first national grant application that was funded. As Tim mentioned, VA self-care, and I'm going to share that in a minute. In 2019, we got a second project funded, this time by the European Union. And in 2020, we secured seed money for a project with an IT switch research center. So let me move now to VA self-care, and I'm delighted to introduce Vittoria. So Vittoria is a conversational agent that runs in a mobile application to help people with diabetes type 2 together with health professionals. So Vittoria is intended to coach older persons with diabetes type 2 on a daily basis by finding out how these persons are doing in terms of their medicines, in terms of physical activity and healthy diet. And Vittoria supports persons in overcoming some difficulties they may have and may advise them to contact their health professionals. So our publications show how we drew on behavioral science and evidence to develop this intervention. And in case you are interested, I can provide more detail in a Q&A. So the information that is introduced in the app will populate or populates a web-based dashboard to alert and support clinical decision by health professionals. So this means that health professionals can use this data to support their consultations with patients. And importantly, it means that any health professional who is authorized by the person with diabetes to access this data can access actually the same data for everyone and can share a common ground to support medication adherence and changes in other behaviors, as previous speakers have mentioned. So physical activity and diet are the cornerstone of diabetes management. So what I'm showing here is a prototype of a conversational agent, which currently has a technology readiness level, so a TRL of 5. So this means that it has been validated in a relevant environment. So we conducted usability tests with 11 people with diabetes type 2, with 9 nursing experts and 17 health professionals. And the dashboard that I'm showing in this slide has a TRL of 3, so it means it is in an earlier stage of development. So moving now to our next slide, I'm sharing now a solution, or actually a couple of solutions with higher TRL. So I'm presenting the results of a EU-funded project, Pro Empowerment. It's a procurement project of an integrated ICT solution for diabetes self-management. So the solution had to address a couple of building blocks of diabetes management. As you can see in this figure here, sort of in an orange color, such as early detection and training. And training covered both persons with diabetes and health professionals, as you can see in the figure. And the solutions that were procured should also address the collaboration between persons with diabetes and professionals through a shared care plan that includes relevant patient data and can be used to schedule some alerts, to set goals, to track progress, and to facilitate shared decision making. And 2 solutions have been contracted, so DM for All and DiaWatch, and both solutions are in a more advanced stage, as I mentioned, of readiness level. So both solutions were certified as medical devices, and one is on the market actually, and the other I'm unsure, but definitely there was a road to market plan. Okay, so this brings me to the final part of my presentation, in which I will briefly touch upon the challenges of adopting these tools in practice. And the first challenge, I would say, is finding an app to collaborate with persons with diabetes and other health professionals. So if you are a pharmacist and you want to go down this road, you might struggle, because there are hundreds of apps in popular stores that are directed at people with diabetes. But firstly, only a minority can be considered as a self-management app. And secondly, the literature has consistently shown that the quality of these apps is often suboptimal, and you may even have some apps with a serious lack of quality or data privacy issues. So how can you overcome this? This leads me to my next slide. Well, if you are a pharmacist and you want to go down this road, I would say that a useful resource to find a quality app with features that can support collaborative work with persons with diabetes is Orca. So Orca is a company that reviews some IT products on the market for clinical assurance, for data privacy, and for usability. And Orica has important customers like NHS England, for example. One downside is that not all information is open access, but it could be something you may wish to invest some time and money on. So, almost coming to an end of my presentation, I'm going to discuss two other challenges in adopting these tools in practice. A first challenge is interoperability. So I'm talking about the issue of different systems, so different IT systems communicating with each other. I looked at the document that FIP launched on digital health in pharmacy education. As expected, this issue is addressed, and in particular, it is highlighted that data from digital health solutions used by persons should be able to migrate to pharmacists' IT systems, for example. And this is, of course, ideal. In pharmacotherapy, there's a principle that sometimes we use, and I think the audience is familiar: start low and go slow. And I would encourage pharmacists to apply this principle to this context and embrace these tools with what is possible now. We know the issues of interoperability are complex and are unlikely to be eradicated in the medium term. Another issue that is critical to foster the adoption of these tools at a larger scale is the framework for service provision. This typically, as Francisco mentioned, as a goal or a dream, this typically needs involvement from organizations and a number of stakeholders, and not only pharmacists individual. So, moving to my last slide, I hope my presentation provided some inspiration to draw on self-management tools in the management of diabetes. If you want to know more about our projects, feel free to access our websites, to follow us on social media, or to drop me an email. And many thanks for listening.
Thank you very much, Mara, for a wonderful presentation and outlining the digital health strategies and the mobile health strategies and the plethora of different apps which are out there. It really is a complicated area from the consumer and the healthcare professional perspective. So we are near on time, but quite a lot of the question and answers have been answered in the Q&A chat. But I would like to ask the panelists to please take a look at the Q&A chat, and then perhaps turn your microphone on if you can see one of the unanswered questions in the Q&A, and share your response to those particular questions. So quite a lot of the Q&A have been answered under the Q&A answered button. But there's still a remaining few questions and comments in there. I would also like to apologise. We had some technical issues with the sharing of the screen at the commencement of the webinar. This can happen from time to time, but I thank you for your patience in that. There is a question on pharmaceutical review in different countries. And Astrid has made a response to that question. Thank you, Astrid. There's a question about sulfonylureas and the place of sulfonylureas in the treatment. And Francisco, I'm wondering whether you can make a brief comment on the place of sulfonylureas in treatment agents such as glibenclamide.
Sorry, please, could you repeat the question, please?
Yes, we know there are challenges associated with the use of sulfonylurea agents such as glibenclamide. What is the place of sulfonylureas such as glibenclamide in type 2 diabetes management these days?
Well, in Puerto Rico, we still use the sulfonylurea a lot because of the price. It is cheap and many people use it, but the thing is that the risk of hypoglycemia is high, and there is not much role besides increasing the insulin secretion, and other medications are improving insulin resistance and have other benefits with less hypoglycemia risk. So these sulfonylureas are decreasing in use, and when the other medication decreases in prices, they are going to continue decreasing in its use. Please let me know if that answers your question.
I think that does. And Mara, would you like to turn on your microphone and ask your question to Astrid? Thank you.
Yes, thank you, Jim. So my question for Astrid is about the use of FIND risk in preventing diabetes type 2 in high-risk persons. So Astrid shared some data about the validation of FIND risk in Switzerland and how this questionnaire is being used in practice. And my question was, how are pharmacists being involved in the prevention of diabetes type 2 in high-risk persons?
Unfortunately, so far, pharmacists are not really involved. Actually, they used to be involved. Like in 2003, we had a self-care campaign which was for free. Unfortunately, you could go into the pharmacy and have a finger prick and test your blood pressure. First, they use the FIND risk questionnaire to see if you had to make a blood test, and the population loved going there, and it was overwhelming, the response. And then in Geneva, they had in a certain pharmacy chain, they actually used the FIND risk on a tablet. It was MSD, which had established this online tool which implemented the screening questionnaire. But unfortunately, MSD stopped providing this tool, which is also a shame, because it was also very well received by the population and the pharmacists to work more in diabetes care. I know there's a large pharmacy chain in Switzerland which does special blood screening for diabetes, but I don't know how often it is used. But they're getting accredited by I don't know, by their own central. It's a quality assessment always what they have to do. So there is some things, but it's all paid out of pocket by the patients. So unfortunately, we don't have anything, no reimbursement by the insurance. The problem is, like in Switzerland, the health insurance is very much physician-based, and the pharmacists, they have no right to get reimbursed by the insurance unless it is in combination with dispensing medicines. This is one piece where we have to move on. I mean, I think Sana, the example Sana showed were very good, that it is very important that the pharmacist gets reimbursed by the insurances, or maybe it's the employer or somebody else, but somebody has to, we cannot ask always the patient to pay. In Switzerland, that's the only way.
Sana, would you like to add something?
All right. Yes, thanks, Timothy. I did see a question about the issue of developing and developed countries, and I know you guys answered these questions, but I wanted to say is that I am working in a developing country, obviously, and it seems that they are the same issues, although progress in developing countries is going to be slower, but the issue of reimbursement is always going to be there. I think, the pharmacists need to document the value of the services that they are providing. And usually in developing countries, I mean, I know this is a general question, but usually in developing countries, governments need to be involved, government institutions like Department of Health or Ministry of Health, or, even academic programs for, pharmacy teaching and learning need to be on board in order for the issue of reimbursement to go forward. But documentation, I believe, is really a main issue that pharmacists need to show, the value of their services before they can attempt to reimburse. And we need to be patient. I think, for the countries or the systems where there is reimbursement for pharmacists, these guys didn't. The reimbursement didn't happen overnight. It really did take time. It does take a lot of work, a lot of convincing, but it will happen eventually. So thank you.
I agree with the documentation aspect, because we as pharmacists do a lot of interventions and education and services, but we don't document anything, and we can demonstrate to the healthcare insurances that we are doing these tasks or interventions for the patient, for the benefit of the patient, and the health insurances benefits of these services that we provide, and we don't document, and we don't ask for his reimbursement either.
I think it's really important to do pilot projects, to document it and to publish it also. Not only document it, but you really have to publish, because for the insurance companies and also in Switzerland, the cantons, the government, they also they are responsible for paying for prevention also, but they don't pay anything if they don't see that you can with better quality, you can reduce the costs. And I mean, as I said, like I mentioned the podiatrists, that they had to show their added value in foot care of patients to prevent foot ulcers, and it took 10 years. It was accepted by the government that the Federal Office of Public Health should find a way to get the podiatrists reimbursed. I mean, pharmacists are already healthcare providers. The podiatrists were not. They first had to become healthcare providers, but this was all in one, and it took them 10 years to show, and huge studies. We had to show that it was really cheaper if they would do prevention than amputations. And with the pharmacists, it's the same thing. Document and with bring the facts, and with the facts you can discuss with the payers. But we cannot always expect the patients to pay, and the insurances, for them it's good. If the patient pays, it's fine. But many patients, especially diabetic patients, they don't always have the resources to pay.
I agree with Astrid and the panel about this very important question, million-dollar question, Francisco, in relation to the payment of professional services. I think there are a number of critical issues here. Yes, we must have high-quality published evidence for the value of the services. The outcome measures in that high-quality evidence should be economic, they should be clinical, and they should be humanistic. So the evidence should span the range of outcome measures in this sense. I think with respect to policy change or remuneration for professional services, we have to choose our timing as well, and be ready with the evidence when the timing is right to present that evidence to the government or to third-party payers. I think almost all of our speakers today talk about the importance of interprofessional collaboration. And actually, if we work with our healthcare professional partners, this is going to facilitate our advancement of remuneration for professional services. I think, as many of the speakers also represented, if we identify the gaps or the or the areas where we can actually improve care. If we focus on those areas, then we have a better chance of seeking remuneration. I think an issue which perhaps hasn't been touched on, which is also important, is the role of consumer advocacy groups. So if we have the consumer advocacy groups on our side, then this can put some pressure on the payers, on the government, to their advantage, and then to the healthcare system advantage. I realise we have gone a little bit over time, but we still have quite a lot of participants online. I think I'm going to draw this session to a close, but before I do that, I just want to quickly go around to each of the panelists and ask them, what's your one tip you have to the participants online with respect to diabetes DSM, diabetes disease state management? And perhaps Sana, we'll go in order. So Sana, what's your one recommendation for our audience here today, please?
Okay, sure. All right, thank you. I think the most important thing here is that obviously we do want to show our value, but I think competence, pharmacist competence, before any pharmacist wants to attempt, whether they have a system for medicines management or any other system where they could be involved in optimizing outcomes for diabetes, is to become competent in managing diabetes. And I'm speaking, with the background of, again, I am teaching right now and practiced in a developed country, in the US, but I'm teaching here in a developing country where pharmacist competence many times is being criticized by other healthcare providers. I know this may sound funny, but it's probably true in many other countries, is that, many doctors criticize pharmacists for not having mostly the clinical competence to manage patients with disease states, and here diabetes. So I think this is where we want to start, is making sure that we are competent and we can provide optimal care for our patients, and that we are of value. And hence, we get the buy-in from other healthcare providers, and we can, I don't want to use the word pressure, but we can show our value to government, health insurance, and consumers. So.
Great response, Sana. Let's go to Astrid, please. What advice do you have for?
Can I just comment on Sana's remark about the doctors criticizing the pharmacists, that they don't have the competency? In Switzerland, it was exactly the same thing, but it backfired for the doctors, because a politician said, well, if the pharmacists don't have the competency, we will have to put it into the law that the pharmacists get the competency in education. So like this, it backfired to the doctors. I think you always have to find ways as a pharmacy association society to turn around and to influence the politicians also to use the negative arguments of the other side for your benefit. But my comment in one recommendation for this is one in response to Sana's comment, but I would also say, like, you have to, as a pharmacist, you have to look for the gaps in the care in your country, in your specific country, and see how you can, as a pharmacist, contribute to close these gaps. Because we don't have to do the same thing that other healthcare professionals already do. But like I showed, it's obvious since 12 years, foot care and the secondary complications, the screening, the self-management is not sufficient. So this is a gap. And if nobody closes the gap, the pharmacist has to close the gap. And then you don't have any conflict with the other professionals, because you're saying we're complementary, we're not taking away your job.
Thank you so much, Astrid. Great observation. Let's go to Francisco, please. One recommendation for the people online, please.
Thank you. The first thing that I would say is that we have to start with ourselves. We have to change our professional culture and philosophy. we have to disconnect a little bit from the product. The medication distribution is needed and it's necessary to support the pharmacy business, but we can do more than that. We need to start with small steps, with small outcomes, and building up over those outcomes. And also, as pharmacists, we have to take advantage of every opportunity that is close to us to open more doors and make other opportunities to show up for us. That's why I say that we have to start with us, because the few opportunities that we have in Puerto Rico, some of the pharmacists doesn't take advantage of it, and the health insurances are going to take them out from us and give it to other healthcare professionals. So we need to change our professional philosophy and culture and take advantage of every opportunity, no matter what small it is, that we have available for us as pharmacists.
Thank you very much. Very insightful comment. And over to you, Mara. Thanks.
Thank you, Tim. Well, I'd say that supporting self-management is critical to achieve better outcomes, because people with any chronic disease, they self-manage 24/7 and they meet their health professionals a couple of times a year. So I say it's doing what we are doing, because pharmacists have always supported self-management and self-care, but I say it's doing what we are doing, but sometimes with a more person-centered focus. And a second message is IT is here to stay. Is here to stay, sorry, and IT is a friend, is not a foe. So I would encourage pharmacists to look at self-management data that is generated in the context of mobile apps, for example, and see how that can support pharmacists in their mission, together with persons with diabetes that are really in the center of the system, and other healthcare professionals.
Thank you so much, Mara. Thank you to all of the participants online. I'd like to draw the webinar to a close and really thank our expert speakers from across the globe. They have really shared decades and decades and decades worth of experience in disease state management with the audience today. I just want to remind the audience as well, fellow colleagues and pharmacists from around the globe, that this is the second of a series of presentations on diabetes. I'd ask you to tune in to the other webinars as well, based on your interest today. So thank you, and good night and good morning and good afternoon, and very much looking forward to seeing everyone next time. Thank you so much.
Thank you very much, and have a nice day.
Thank you. Nice to see you, Mara, again. I don't know if you remember me from ESCP.
Of course, Belfast. I was going to